Assalamu alaikum everyone. My name is Dr. Mavish Erkin. I'm the director of the academic wing at Ventilators for Pakistan and the co-founder of Yatin Foundation. I would like to welcome everyone to the second last session of the COVEB series, where we will be discussing pediatric with respect to COVID-19. Our experts will be shedding light and giving their insight on how COVID-19 has impacted the field of pediatrics. I would like to mention that this session is part of educational activities taken up by Ventilators for Pakistan. From its humble beginnings in an effort to support the healthcare system of Pakistan, VFP has now become a name of its own, thanks to the visionary guidance of its founders, Dr. Sabah Akhtar and Dr. Abil Tariq, as well as the unrelenting efforts of all its members. I would like to mention some personalities without whom this web series would not have been possible. The patron-in-chief for this series is Professor Emeritus Lieutenant General Mahmood Ahmed Akhtar, Hilal Imtiaz Military, and our patron is Professor Dr. Samia Naimullah, recipient of the President of Pakistan Gold Medal by Pakistan Pediatric Association. Thank you, ma'am and sir, for your support. I would also like to take this opportunity to particularly thank Rawalpindi Medical University, which has accredited these educational series for all of you to enjoy. Thank you to the Vice Chancellor and the medical education team of RMU. I would like to introduce my co-host for the evening, Dr. Zaid. And before we move forward, I would like to give a little tribute for the departed soul, Dr. Muhammad Nimullah, our beloved patron's husband. Dr. Muhammad Nimullah was born on 10 December 1950 in Lahore. He was the youngest son of Professor Dr. Colonel Ziaullah, a renowned physician of Lahore, professor of medicine at King Edward Medical College and the Fatma Jinnah Medical College, Lahore. His schooling was from Cathedral School, where he had the highest IQ among the whole school. Dr. Naimullah graduated from King Edward Medical College in 1975 and got married to Professor Dr. Samia Naimullah in December 1975. He proceeded to the US in 1976 with a lot of difficulty when there was a complete ban on doctors, as army service was essential. However, nothing could stop him, as it was his passion to train in the United States. He completed his residency and fellowship in diagnostic radiology. After returning to Pakistan, he was a pioneer in diagnostic imaging and established first ultrasound, first CT scan, and then the first Doppler ultrasound. The first intrauterine transfusion in Pakistan was done in his clinic under Doppler guidance with Professor Yasmin Rashid, who was professor of gynecology here. Professor Naimullah has trained multiple doctors and technicians from all over the country. He did a lot of academic work. He was very compassionate and would not charge to serving patients just like his father. His contribution to the field of diagnostic radiology was enormous when radiology was only limited to X-rays. He carried out free courses to train doctors in ultrasound at Holy Family Hospital. There are many research papers to his credit as well. He had a great sense of humor, loved reading, sports, and music. An amazing human being, completely devoted to his work. He was an honest and a pious man. Professor Naimullah was an affectionate father, a loving and caring husband, and an adorable brother, very attached to his elder sister, Professor Dr. Khalda Adib Khanum Akhtar. He was also very close to his nieces and nephews and has left everyone heartbroken when he departed for his final destination on the 3rd of September 2020. He was the brother-in-law of the patron-in-chief, Lieutenant General Mahmood Ahmed Akhtar, and Professor Muhammad Tayyib, husband of the patron, Professor Samia Naimullah. His legacy of helping everyone will be carried on by his son, Muhammad Akil. A moment of silence for the departed soul. I would like to briefly talk about Yatin Foundation. As I am the co-founder, Yardım itself translates to help in Turkish, and together my sister and I, we founded this organization a little over a year ago with the sole intention of helping our nation, specifically orphans, widows, differently abled, and other marginalized sections of our society. Yardım family includes a group of 45 hardworking and extremely talented members without whom the foundation wouldn't be where it is today. We currently have three running programs: Yardım Dental Program, our Mental Health Awareness Program, and the Food and Ration Program. The dental program is a pioneer initiative under which we organize dental camps to create oral hygiene awareness, conduct free dental screenings, provide free dental kits to the children, and also ensure free dental treatments in underprivileged communities and schools in collaboration with multiple hospitals. We initially began by visiting various summer camps and schools in Islamabad, including Westminster School and TSC Daycare Center. This was done with the intention of increasing hygiene awareness among children by especially teaching them the proper brushing techniques while simultaneously ending the fear of dentists among them. In an attempt to make a change, we then decided to target marginalized communities in our society for whom these facilities are out of reach. We visited orphanages such as the SOS village in both Rawalpindi and Islamabad, as well as underprivileged schools including Hunehar Welfare School in G12, Mashal Model Charity School in Bari Imam, where we conducted screenings for about 800 children, the Gateway School in Dok Saida in Pindi, which was an open camp for the entire area, and many more. By the grace of Allah, so far we have organized camps for over 1,300 children and also made sure to provide the necessary treatments. Our second program, Mental Health Awareness Program, was initiated to spark the conversation to end the stigma surrounding mental health in Pakistan. We as an organization decided to take to our social media platform to raise awareness about different well-known or novel mental illnesses. Our campaigns take on specific mental health themes per week and are subdivided into the following three. Hashtag Mental Health Mondays to reinforce learning to value ourselves and others and understanding more about the people around us. Talk About It Tuesdays to give everyone a platform to share their stories, hear others, and collectively work on becoming more empathetic and sound individuals. And lastly, the Wellbeing Wednesdays. This subdivision focuses on promoting awareness and providing self-help guides through online activities and resources. We recently started a movement on social media, hashtag How I Cope, to celebrate the diversity of coping mechanisms that different individuals follow in times of stress or hardship. Through the current period of such uncertainty, where the whole world finds itself in one pothole after another, it is vital to look after one's mental health. Coping mechanisms help individuals in maintaining their emotional equilibrium. Some like to talk about their issues, while others to gain emotional clarity, whereas others like to address their challenges by joking about it. No two individuals have the exact same coping mechanism, and that is the beauty of it. Before the unfortunate pandemic, the mental health team would make frequent visits to underprivileged schools where we would collectively conduct art therapy activities. The goal of these activities was to enable emotional intelligence in these children and to motivate them to be able to express their feelings openly by understanding themselves first. Our third program, the Food and Ration Program, was started during the pandemic, and so far we have helped 700 plus families. In May 2020, it was published in the Washington Post that the consequences of the coronavirus pandemic may prove more devastating than the disease itself for the world's poorest countries. In fact, even before this pandemic, it was established by WHO that in every 10 seconds, a child dies of malnourishment. Due to the overwhelming support we received, we started a long-term program to provide monthly ration to families with no means of support, such as widows, divorcees, orphans, handicapped, and other medical patients. In this program, sponsors can choose to provide funds to cater to a family for a specific time period, a month, 3 months, 6 months, even an entire year. Every month, our members personally purchase, pack, and deliver the ration packs. Participants, during the live session, don't forget to comment with your name along with your designation, and in the end, fill out our feedback form to mark your attendance. I would now like to hand over this to Dr. Zaid to introduce our speakers.
Thank you, Dr. Memish. Now I'd like to start off the evening with our first speaker, Dr. Ijaz Khan. Dr. Ijaz Khan. Dr. Ijaz Khan is a professor and chief of pediatrics and infectious diseases at Shifa International Hospital and Shifa College of Medicine, Islamabad, Pakistan, since November 1997. He graduated from Aga Khan University, Karachi, Pakistan in 1988. He did his pediatric residency from University of Florida, 1991 to 1994, and pediatric infectious disease fellowship from Baylor College of Medicine. Used in Texas, 1994 to 1997. During this time, he acquired his American Board of Pediatrics in 1994 and the American Board of Pediatric Infectious Diseases in 1997. He is currently the Chief of Infectious Disease Control and IRB at Shifa International Hospital. I would like to now welcome Dr. Ijaz Khan.
Hello, Assalamu alaikum. Can you hear me?
Yes, sir. Assalamu alaikum.
Yes, sir, we can hear you.
Okay. Can I have my slides, please? Thank you.
Of course, sir.
So we are talking about COVID as children. We know that children are one of the groups that we think are vulnerable, but this pandemic has us probably otherwise. Objectives of my talk today. Can I have the next slide, please? Next slide. No disclosure. Next, please. Thank you. We're going to talk about pathogenesis, and we're talking about epidemiology and clinical features and diagnostic and then management. So we'll try to finish it in about half an hour because I have an engagement and I have to go in half an hour. So next slide, please. Thank you. Next slide. Next slide, please. Talking about pathophysiology, as you know that this is syndrome has brought about some new aspects of lung disease, which includes this cytokine syndrome, which is characterized by ARDS and macrophage activation syndrome. And there is a significant period of immune dysregulation, and which is also has sepsis-related fatalities. Next. Next slide, please. So this shows a cartoon shows about the main features related to lung injury, which is compared to normal state. This is severe COVID. You have vascular leakage, clotting, and then inflammation. So these are the basic three mechanisms that we know happens in the lungs. Next slide. And this is basically shows about the initial inflammation, which is characterized by monocytes, macrophage, and then you have two different varieties. One is by low virus titer and then is high viral titer. So you have the severe disease in which the virus titer is probably much higher, and so you lead to have mild disease or severe disease. And this is characterized by what we call cytokine syndrome. This is a lot of IL-6 and IL-10 and TNF releases in the lungs, and where we can always have focused treatment. And there are other cells also involved. Compared to the severe disease, in normal mild disease, you have minimal or uh, inflammation and minimal involvement of these immune cells. Next slide. Next slide, please. This graphically shows you the initial especially in the incubation period, and then you have the dramatic
Excuse me, sir, if you could hear me, could you please repeat the current slide? I think there's an internet issue, so we're unable to hear you from our end. We're losing you, so could you please repeat?
which there is
The current slide.
inflammation. I can't.
Sir, I'm sorry, I can't hear you at all. I think we lost Professor Jaz. We're trying to get him back online, and hopefully that will work.
Yes, hopefully soon. I think his connection dropped towards the third slide, I believe.
Yes.
Before he was talking about the pathophysiology of coronavirus at that time.
Yes, exactly.
Hopefully he will be back soon.
He's
I think
back.
we have Dr. Jaz back. Let's see if he has a stable connection at the moment.
Professor Jaz, can you hear us?
Sir, can you hear us?
I think if Professor Jaz is having some connectivity issues, we can start with our second speaker. We can have him first. He's all the
I
way
think that'll
here
be a
from.
good idea.
Yes. And I'm honored to announce that our second, now first speaker for tonight is Professor Dr. Bishara Fraij, who has taken out valuable time to present some very interesting cases all the way from United States. Professor Fraij is a pediatric infectious disease specialist currently working as the director of this division at Beaumont Children's Hospital, Oakland University, USA. Professor Bishara graduated from the American University of Beirut in 1980 and then pursued a residency at Georgetown University School of Medicine in 1983. Following this, he practiced in the University of Texas Southwestern's fellowship program in pediatric infectious diseases. In 1985, he also pursued a fellowship in infectious diseases from the National Institute of Neurological Disorders and Strokes. Professor Bishara cares for patients who have serious underlying diseases such as leukemias, Crohn's disease, and immune deficiencies, in addition to children suffering from bone infections and meningitis. Please allow me to welcome Professor Bishara to enlighten us with precious knowledge from his end. Welcome on board, sir.
Thank you, Dr. Erkin and Dr. Hussain. Thank you for inviting me. The case that I'm going to present is a case that one of your colleagues, Dr. Tariq, was a senior resident on in the pediatric intensive care unit. We dealt with this child in April of this year, early in the COVID epidemic that hit Michigan. And at that time, of course, since that time, a lot of the knowledge about the disease has grown quite a bit. If you follow PubMed, you will see thousands upon thousands of publications that are appearing all the time. But we thought it would be an interesting case, a cautionary case to present. If I can have the first slide.
Yes, of course.
Next slide then. So this is an almost 6-year-old, previously healthy African-American girl who developed fever and headache and was seen by her pediatrician on the 3rd day of fever. They swabbed her throat, got a positive rapid group A strep screen and put her on amoxicillin, but she did not get better. She continued with daily high fevers of 39 plus degrees centigrade and severe headaches. So she presented to our hospital on day 6, and on admission, they did the routine labs, and she had a white count of 10.8. The lymphocytes were 1.8. Her sedimentation rate was 30. She was a little hyponatremic, normal liver enzymes, normal chest x-ray. And because we were in the midst of the pandemic, a nasopharyngeal swab for SARS-CoV-2 was done, which was positive. Interestingly, the father, a few days before, had been at the emergency center where he was diagnosed with COVID-19, had very bad pneumonia, and was improved by the time this child started getting sick. And the mother was sick with very mild respiratory symptoms around the same time as the father, but never got ill, never got assessed. The father had been swabbed. He was positive for SARS-CoV-2, and the mother was never tested. But a few weeks later, I obtained IgG antibodies on both of them, and they were both quite positive. Next slide, please. So in the hospital, she remained stable, but had persistent daily fever and persistent headache. She was managed with pain medications, and her status would wax and wane, but otherwise she did not develop any new problems. On the 9th day, the hospitalist taking care of her was getting very concerned about the headache, so did a head CT scan, which was normal. And so the child was sent home on day 10 because she seemed better, eating better. And then a few hours later, while in the car, she developed a 2-minute episode of confusion, and the parents described her extremity as stiffening, and she seemed to be staring into space. So they were worried about a seizure, ended up in the emergency room, and the laboratory studies at that time, the white count was 11.1 with lymphocytes of 1.1, so a drop in lymphocytes. And her platelets were normal. Sodium was 130. Now the sodium, the hyponatremia she had on the first admission had corrected before discharge. So she developed a sodium of 130. And her inflammatory parameters that we use to assess the hyperinflammation associated with COVID-19 were all normal. Her ferritin, LDH, fibrinogen, troponin, interleukin-6 were all normal. Her D-dimer was mildly elevated. In our lab, up to 500 is normal. She had a lumbar puncture this time, and the fluid was clear. She had 24 white cells, of which 96% were lymphocytes. A few red blood cells. Her protein was mildly elevated at 85, and her glucose was low, 22. We did not have a peripheral glucose to compare it to assess the CSF to blood ratio. We did a meningitis encephalitis molecular panel, which was negative. This panel has 13 targets that include herpes, varicella, herpes 6, a variety of bacterial pathogens that are important in meningitis. We did another we did a SARS-CoV-2 RNA test on her CSF, and it was negative. Next slide, please. So this is an MRI done on day 12 of fever. And if you look at the left side panel, you see on the diffusion weighted images a 7 millimeter area of restricted diffusion in the left anterior frontal lobe, subcortical white matter. So to us, this seemed to be a case of COVID-19 related encephalitis. Based on this image, we thought maybe the entry point was the olfactory bulb, which has been suspected to be an entry point for the virus into the brain. Because of that, we decided to start treating the child with hydroxychloroquine and azithromycin. Now, at that time, as if these medications were considered beneficial based on very preliminary data. Because of the child's progression and worsening, we felt we had no choice except to do that. Next slide, please. So we gave her 5 days of hydroxychloroquine and oral azithromycin. She developed inappropriate secretion of antidiuretic hormone, was managed initially with fluid restriction, frequent 3% saline boluses, but her fever persisted, daily fever, and her mentation and headache would sometimes be better, sometimes be worse. And then on day 15 of fever, this is from onset of disease, she developed increased lethargy and her pupils were asymmetric. So we repeated the head CT and it showed enlargement of her lateral third and fourth ventricle. So she had hydrocephalus. So another lumbar puncture was done the next day safely, and her fluid this time was hazy. There was high opening pressure. The white count was now 160, of which the lymphocytes were now 51%. Glucose was improved at 30 and protein was higher at 112. So we repeated CSF SARS-CoV-2 RNA and it was again negative. An external ventricular drain was placed to relieve the pressure. Next slide, please. This is the repeat MRI, and you can see two things. So on the left panel, you can see the left image. You can see that the original lesion that we saw in the left deep frontal cortex had faded. So that seemed to be better. But if you look at the middle panel, you will see a lot of areas of hyperintensity. The white stuff in the deep frontal and midbrain and in the deep temporal areas. So these were new. The original lesion disappeared, but these appeared. And on the right side, you can see an MRA showing normal vessels and normal circle of Willis. And this will be important for the subsequent course. Next slide, please. So at this point, we had finished with the hydroxychloroquine and azithromycin, but because of the worsening, we decided to start dexamethasone with the assumption that what we are dealing with is the hyperinflammatory response in the central nervous system related to the viral illness. She had to be intubated. We were able to secure remdesivir at the time, which was still investigational and required FDA clearance to allow us to use it on this child. So this took a day to get the drug at the time. And the chest X-ray showed early perihilar tracheopacities for the first time. This was felt to be related to the intubation. We repeated all the inflammatory markers in the blood, and they were normal. And the subsequent days involved very turbulent problems for the child, including severe SIADH, severe hypertension, worsening chest radiographs, and appearance of bivascular opacities on day 27 of fever. An EEG was done, which showed severe encephalopathy. The pupils became dilated and minimally reactive. Next slide, please. We had obtained a whole bunch of laboratory data during the hospitalization, and her absolute lymphocyte counts had dropped and were all 1 or less during the last 2 weeks of her illness. So when we started, it was 1.8, but this dropped quite a bit. Her liver enzymes remained normal throughout. We tested her for HIV, and it was negative. And on the spinal fluid, we did some autoantibody testing, and she actually was positive for glial fibrillary acidic protein autoantibody, which is something that indicates injury of astrocytes and is not specific for any one entity. You see it in severe encephalitis and a whole bunch of other problems, but that suggested to us that there was additional components of injury that involved the immune system. Next slide, please. Now, we had the opportunity to do serologies at the time. This is a test called Euroimmune, which is a German company assay. And we had serum from day 11, day 22, and day 32 of illness. And if you look at the orange line, this is IgA specific, SARS specific IgA. And you can see it went from negative to positive to even, I'm sorry, the orange is the IgG, the blue is the IgA, and it was, when we tested it on day 11, it was just a hair above the cutoff and became positive, and it jumped up quite a bit to a peak of 11.77 units on this ELISA assay by day 22, and then started declining, and the IgG steadily increased from negative to positive to more positive. And I have the actual ELISA values for you at the bottom. So what this slide showed is that this is not an old infection with persistent RNA in the nasopharynx, but this is an acute infection that we were dealing with because we are demonstrating seroconversion, as you would expect with pretty much any infectious agent. Next slide, please. So this is an MRI on day 30 of illness, and on the left side, you see a T2 flare study that shows extensive lesions. I mean, you see all the white there. This is the whole, much of the brain is involved now. And on the right side, this is shows the MRA. If you remember the earlier MRA I showed on day 16, now you see that there's no flow in the intracranial vessels. So basically, this child had severe ischemia. I mean, the brain was not receiving any blood flow. Next slide, please. So because of that, she underwent an urgent suboccipital craniectomy and C1 laminectomy on day 30 of illness. And when the surgeon made the cut, the cerebellum herniated out of the surgical defect. There was so much high intracranial pressure that it just popped out, and the cerebellum was grossly necrotic and edematous. The surgeon did a cerebellar biopsy, and we did a a PCR assay on the cerebellar tissue. So this is not CSF, but actual brain tissue. And this time it was positive for SARS-CoV-2 RNA. Next slide, please. And from this biopsy, this is later, this is after the patient passed away, we were able to find the virus by electron microscopy in the cerebellar tissue. So it wasn't just the PCR that was positive, but also electron microscopy. And in this image, you see a vesicle with multiple virus particles within it. And you can, if you look carefully, you can even see a little bit of these spike proteins visually. This was confirmation that the virus was indeed in the brain. Next slide, please. So we thought this is what we had. The child, we were trying very hard to get an autopsy. It took a lot of discussion with actually not the family. The family was willing to do a limited autopsy, but our anatomical pathology colleagues were a little reluctant because doing a brain autopsy involves sewing the skull bones, which will generate a lot of debris in the air, and there was a lot of concern at the time about infecting others during the procedure. Ultimately, they were willing to do it. And next slide, please. A few days later, I got a call from the pathologist to come down and see the patient, to see the slides, the surprise in the study. And what the anatomical pathologist found is necrotizing granulomas. And on the left panel, you can see the necrotizing granuloma on low power. And then panel B is the high power, where you see where the arrows are pointing, a lot of acid-fast bacilli. And on the right side, you see a medium-sized blood vessels. And if you look at the vessel wall, it's severely damaged. All the cells there, this is like severe vasculitis with incredible damage to the vessel wall. And high-power view of the vessel wall shows also many gram-negative acid-fast bacilli. Now, in general, in TB meningitis, the number of acid-fast bacilli that are seen is very scant. You don't see this many lesions, this many bacteria on any one slide. So this seemed very unusual for a Mycobacterium tuberculosis, and raised concerns at the time that this could be maybe an atypical mycobacterial species. Next slide, please. So the first question we had was, did the child really have SARS-CoV-2 central nervous system infection? And the answer we felt was yes, because we had repetitively recovered the viral RNA from nasopharyngeal swabs, so the possibility of false positive results was excluded. We did have serologic evidence of acute infection showing seroconversion with specific IgG and IgA. We did have cerebellar tissue PCR that was positive, and we did have the electron microscopy picture that showed viral particles within a vesicle that was consistent with the coronaviruses. So with all of these, we felt we had plenty of evidence for nervous system involvement with this virus. Next slide, please. Now, when the child was in the ICU, there was discussion about the possibility of TB meningitis. And in fact, The person that first raised the issue is your colleague, Dr. Rabia El-Tariq. She was wondering if that could be there, and the family history was negative. We did discuss with the parents any TB exposures, and the answer was no. And then we just felt that this was not likely. Clearly, that was not correct. In the end, we ended up doing some other studies for mycobacteria after the patient's demise. Now, we had saved a lot of samples on this child as we went along, so we could retrospectively go back and look at things. And we never did a tuberculin skin test or the interferon gamma release assays. The cerebellar biopsy, we sent the tissue sample to the University of Washington in Seattle, and it was positive for Mycobacterium tuberculosis complex DNA. Now, Mycobacterium tuberculosis complex is about 10 different mycobacterial species that can give you TB disease in humans. So it doesn't tell you that it's Mycobacterium tuberculosis specifically or any one of the others, but it was a positive for that. And they do have an atypical mycobacterial DNA probe, which was negative. So this did not fit with atypical mycobacteria. Now, we were not able to obtain a culture of the cerebellar biopsy because the surgeon had put the biopsy in formalin, and it was fixed, and it was not possible to get a culture. Now, we did have tracheal aspirates collected on days 22 and 27 of illness. They were both negative for Mycobacterium tuberculosis, complex DNA, same story. But both eventually grew acid-fast bacilli after about 8 weeks of culture, which was confirmed to be Mycobacterium tuberculosis later. So it wasn't just Mycobacterium tuberculosis complex, but now we actually knew it was specifically Mycobacterium tuberculosis. We had ventricular spinal fluid from day 25 that failed to grow mycobacteria, and more ventricular fluid from day 28 of illness that was negative for mycobacterial DNA. We were also able to obtain whole genome sequencing on blood through the NIH, the National Institutes of Health in Bethesda. This study is not completed, but it found that the child had 2 mutations for the interleukin-12 receptor beta-1 subunit variants. Now, the question whether this is, these defects can increase your risk for severe mycobacterial disease if you happen to be a carrier. Both the Mycobacterium tuberculosis or atypical mycobacteria, and can give you disseminated disease. The problem we have right now is we do not know if these two, since it's not the same mutation, it's 2 mutations, they could both be on the same allele on one chromosome. Thus, it would be like a heterozygous result. And we don't know if they're one each is on different alleles. So for those, we are trying to get some laboratory studies on the parents to see if each one of them carried one variant, then we can say that the child had basically both abnormal alleles. The parents have not yet given blood to do so, even though they've agreed, but that hasn't happened yet, and we're hoping to get that done in the near future. Next slide, please. Now, once the child was identified as being infected, I managed to get the family tested because, as I mentioned, the family history was negative. And the mother, father, and grandmother who live in the same household, as well as the maternal aunt, who is 3 adults who are in constant contact with the child and her family, all were tested with the quantiferon TB assays and chest x-rays, and they were all normal. None of them had symptoms of anything. There were no known contacts with tuberculosis among their friends or at school. But contact tracing by the health department was hampered by the COVID-19 pandemic. I mean, there was just everything was on lockdown and nothing was possible. We have recently identified the genotype as G08464. Now, this is an interesting genotype because over the past 13 years, there have been only 14 cases with this genotype in the United States of Mycobacterium tuberculosis. 12 were from the Detroit area, excluding this child. These data are until the end of June, and this was identified actually just recently. This genotype accounts for 1.25% of Michigan cases and only 0.02% of all cases in the United States. Our cases, the Detroit cases, the 12 Detroit cases over 13 years, all of them were African American. Most of them were males. Most of them were born in the United States. None were in children under 14 years of age. Next slide, please. This is a schematic of the cases, the clustering of cases, and you see this is by quarter in different years. So it's kind of been very sporadic, and since the second quarter of 2019 into the second quarter of 2020, there were 3 cases, excluding our child. We are still trying to figure out if there is any link between these cases and our child, and this is ongoing with the Michigan Department of Health and Human Services. So I don't know the answer to that yet. Next slide, please. Now, I wanted to show you TB cases in the United States. Now, the United States is not like the Middle East or Southeast Asia, where TB is a little more common. In the United States, TB is much less frequently diagnosed. On this slide, it shows all the TB cases from 93 to 2018 and with the age breakdown. And our child would be in the green bar, which is way at the bottom of the slide. And you can see there is like very, very rare cases of this in this age group. Next slide, please. If you look at TB cases by age group now, between 93 and 2018, and again, our patient now is not, they changed the colors here, so it's in the sort of reddish brown hue they use there, and you can see the number of cases, especially if you look at 2018, which is the last year we have data on, is a very small number of patients. This is for the entire United States, not Michigan. Next slide, please. And this one divides the number of cases per 100,000 population, and you can see, again, now we're back to green for this child's age group. And her age group has the lowest case number per 100,000 population, and it's really is near zero if you look at 2018. Not quite zero, but very close to it. Next slide, please. Now, when you look at the TB cases in the United States among children and look at the parents and where the child was born, where the parents were born, the U.S.-born children, which is our patient with U.S.-born parents, which is our specific case, you can see that the blue bar in here is much smaller, indicating that most of the cases in the United States are U.S.-born children with non-U.S.-born parents. So again, our child, even within the unusual age group for disease, is also unusual in terms of being U.S.-born with U.S.-born parents. Next slide, please. What makes it even more unusual is that within the United States, if you look at 2018, extrapulmonary disease accounted for only 20% of patients versus 80% with lung disease. And within that, only just a little less than 4% had meningeal involvement. This is not age-related. This is all comers, adults and children. So these were. This is a very unusual scenario for us in the United States. And in fact, I was thinking back in my career now that's in pediatrics of about 40 years. This is maybe the fourth child that I've dealt with that has the disease, had the disease. Next slide. Looking at Michigan numbers for TB, our hospital is located in Oakland County. The child lives in Wayne County. Detroit belongs to Wayne County, is within Wayne County. And you can see these are the total number of Michigan TB cases, adults and children. And in 2019, there were 45 cases of TB in Wayne County and 21 in Oakland County. Next slide, please. And if you look at children and you look at the 5 to 14-year age group, which is where our child belongs, there were 5 diagnosed with TB in the entirety of Michigan, not in the Detroit area specifically, but the entirety of Michigan for both years. Next slide. So we were clearly dealing with a very odd situation here. Now, in the next few slides, I wanted to discuss what has since developed in terms of our knowledge base about nervous system involvement in COVID-19. And you are seeing, if you follow the literature, increasing reports about neurologic symptoms associated with COVID-19. And some studies have looked at frequency of these neurologic abnormalities, and they varied from the mid-30s to the mid-80s. And now that includes everything that you can think of that may constitute the neurologic symptoms, from headache to lethargy to seizures, etc. And the specific neurologic associations that have been described include encephalitis, encephalopathy, acute disseminated encephalomyelitis, myelitis, Guillain-Barré, loss of smell, loss of taste, strokes, ischemic strokes, hemorrhagic strokes, venous sinus thrombosis, psychosis, memory loss. So a lot of those are features of, and you'll find these cases published in the literature if you look it up. Next slide, please. Now, how does the virus enter the nervous system? How does it cause problems? Well, there are several mechanisms of nervous system involvement. So SARS-CoV-2, the receptor for that is angiotensin converting enzyme 2, and this is expressed in the glial cells and neurons. And in laboratory studies, SARS-CoV-2 has been shown to kill some neurons and reduce the formation of synapses. So it can be really injurious when directly infecting cells. The one thing I will mention is the ACE2 expression in the brain is not extensive. So, and that's part of maybe having difficulty finding SARS-CoV-2 RNA in CSF samples. Patients can have coagulopathy and develop, they can have endothelial injury and dysfunction. They can have immune-mediated injury with elevated cerebrospinal fluid cytokine levels, and they can demyelinate like you might see in MS-type patients. Next slide, please. Now, cerebrospinal fluid studies in COVID-19 have been very limited. When you look at big series, you'll find very limited CSF data. Most of them are not getting tapped. PCRs and CSF are almost always negative. I mean, it's rarely described as positive. I think there was only one case where that was the case. And most lumbar CSF shows no pleocytosis. so no increased white cells. Now, the problem with this, of course, is the variety of findings for neurologic symptoms, like I mentioned, loss of taste, loss of smell, psychosis, etc. All of these may not be related to direct CNS invasion. There was a paper by Boudreau et al., and this is listed in the reference section at the end of this talk, described 2 adults with encephalitis from this virus, and they found spinal fluid counts of 90 to 95 with mostly lymphocytes, high protein, 105 to 115, and the glucose was normal in both patients. So for our child, everything fit except the glucose in the spinal fluid. And this paper came out actually, after our patient passed away. The virus has been hard to find in brain tissue, but has been seen with electron microscopy in some studies where they've looked hard for these things. Next slide. Now, what about TB meningitis? Well, the CSF and TB meningitis is generally clear. The white counts are highly variable, as the audience well knows, can be from as low as 5 to as high as 1,000. The lymphocytes predominate. Protein varies from, can be 50 to 300 milligrams per deciliter. You will usually see low glucose with CSF to plasma glucose of less than 50%. Now, there are several cases in the literature of TB meningitis patients with normal glucose in the CSF, normal protein in the CSF, normal white blood cell count in the CSF, and even neutrophil predominance in the CSF. When you do nucleic acid tests on the spinal fluid, the sensitivity was only 56%. So not the best test, but it is helpful if positive. Next slide, please. Now, what made this case especially concerning, other than the fact that something rare had happened to this child, is about a third of the world population is TB infected. And the question is, does the mix of COVID-19 and TB have implications for either disease? So there's a lot of actual data in the literature already looking at, these are in vitro studies. They've looked at influenza, HIV, and measles virus separately, and in experimental work, infection of this virus in animals either previously infected with TB or co-infected with TB at the same time these viruses are introduced, was shown to impair the ability of macrophages to contain mycobacterial growth. So basically, mycobacteria multiply quite a bit in the presence of these viruses. The body loses control of this problem. We know that lymphopenia is a risk factor for severe or fatal TB, and this child had lymphopenia during the latter half of her life, of her hospitalization, and even her admission lymphocyte count of 1.8, while normal for a child her age, is not particularly high. Now, there's a paper that just came out, this in preprint form, which I found very supportive of what we're thinking, where they looked at mouse stem cells that were infected with the dormant Mycobacterium TB. And when they infected these by mouse coronaviruses, which is the closest equivalent to SARS-CoV-2, the response of these cells is to produce an innate defense against the murine, the mouse coronavirus, MHV1, and that these responses enhance the antiviral activity against the virus. But the cost of this response is allowing dormant TB bacteria to undergo replication intracellularly and be released extracellularly. So this actually is very concerning in terms of dormant disease. So if that translates to humans, you're talking about a lot of people with latent TB who could potentially activate their MTV during COVID-19 acute infection. Next slide, please. So I borrowed the title from Gabriel Garcia Marquez's book, so I'm giving him credit for that. So for tuberculosis in the time of COVID-19, there is remarkably limited data on active TB patients who get COVID-19 in the literature so far. And what is available generally shows that if the patient is diagnosed and is on treatment, when he or she gets COVID-19, there may be limited worsening during the COVID infection. But these are people who are already recognized and are on treatment. There's no information on latently infected children or adults who get COVID-19. We do not know what happens. So the other concerns have to do with the COVID-19 pandemic and its effect on TB control programs in the United States and everywhere, actually. So in the United States, a survey by the CDC noted that about 2/3 of all TB control programs in the United States have experienced partial or high impact staffing capacity. A lot of their staff were rerouted to do COVID work, and so they are not able to do as much diagnosis or treatment of active or latent TB, contact investigations, targeted testing, treatment of latent TB in high-risk populations, case reporting, etc. And in low and middle income countries, the negative effects include diversion of resources and the loss of the focus of the healthcare on TB control. And in a lot of these countries, there are a lot of people walking around who have lung damage from prior TB or active TB and may be more susceptible to severe disease. And the biggest, not the biggest, but another big factor is the overlap of symptoms leads to diagnostic confusion, and there's a limitation in terms of what people can do to diagnose things accurately. And just a note, there's no evidence that BCG vaccination protects against SARS-CoV-2 because this has been bandied around in the literature quite a bit. There are 2 large WHO studies going on now to assess that, but our child did not get BCG vaccine anyway. Next slide. In the U.S. and everywhere else, because of the reagent limitations, the desire not to do too many aerosol generating procedures on patients, there's been a lot of limited evaluations of sick children and adults where people just basically diagnose COVID and then move on and blame everything on COVID. So most COVID deaths are being attributed to the virus itself, whether from the viral infection or the cytokine storm that is associated with that. And the question has been, do people die from COVID-19 or die with COVID-19? So looking at our child, we know that the child was acutely infected with SARS-CoV-2, but died of fulminant TB meningitis. This child, our hypothesis is the child was either latently infected, but never tested because testing is not part of routine care in the United States, testing with PPD, but also that she might have been recently infected from somebody, and that the SARS-CoV-2 infection just allowed the mycobacteria to replicate and disseminate very fast and in large numbers into the CNS. An autopsy, we did find it in the lung, in the spleen, but the organ that was most affected was the brain. Whether the child on top of it had these gene defects in the that increased your susceptibility to severe disease remains to be ascertained. Next slide, please. So here I put in the main references, including, we have recently published this paper. It came out on September 9th, which is, you can see the third reference, and you can see Dr. Tariq's name there on the paper. She worked very hard on this patient. These summarize pretty much everything I have included in the presentation. Next slide, please. So I'm done with the talk. So if anybody has any questions, this would be, I guess, the time.
Questions from the participants. So with your permission, I would like to ask them. Our first question is,
go ahead.
What is the fertility rate amongst children who are COVID positive?
Extremely low, extremely low. The numbers are a little hard to come by. If you look at the more severe form, which is the multisystem inflammatory syndrome, which Dr. Rathore, I think, is talking about tomorrow, the mortality rate in various studies was from 0 to 2%. And that's the most severe form of the disease. Yeah.
Okay, thank you, sir. Sir, the second question is, what are the most common presenting symptoms amongst children?
With what? With COVID-19? So if you're talking about COVID-19 in general, they can present with respiratory illnesses like the adults, so fever, cough. If you look at the literature, though, so what's happening is a lot of patients are being tested if they get into the hospital for any reason for infection control purposes, and so you'll find that there's all sorts of presentations. We don't really think about it unless there is exposure or they have respiratory symptoms, and that is the most common. But the more severe form, the multisystem inflammatory syndrome, which is the one that again will be discussed tomorrow, they can have those plus vomiting, a lot of GI symptoms, diarrhea, abdominal pain, and so those are all part of the things we look for.
Okay, thank you, sir. Sir, we have a question regarding the MRIs. Were there findings shown in the brain due to COVID regarding the MRIs?
So we cannot tell. We think most of the abnormalities were TB related. So MRI studies in COVID patients are largely in adults, and those usually are people with severe neurologic symptoms, strokes, etc. So there is no MRI of any just people with COVID who don't have CNS disease. I think, but I can't prove it, is the first lesion we saw in the left frontal cortex was COVID related, and because it disappeared at a time when the patient was improving. Disappeared as the patient was getting worse clinically and developing new lesions elsewhere. I don't think that lesion was a TB lesion because there was no reason for it to have disappeared. In fact, it should have stayed or gotten worse, but it clearly was gone. So that one, I think, is likely related to COVID, but I cannot prove it.
Okay, sir. Thank you so much. Sir, another question. How common are neurological findings seen COVID-19 in the pediatric population?
So again, so in the pediatric population, you have to be careful with what you call neurologic symptoms. So sick kids are often described as lethargic. I mean, anybody who does pediatrics will hear that term. If they don't eat well, if they, if they become less active and they're described as lethargic. So lethargy is the biggest thing. And if you include that, then that's a very common feature, but it's also not specific. We don't have a good handle on neurologic disease in in the pediatric population related to COVID-19. There are cases of seizures. There are cases of, people will describe these commonly in series. If you look at series, the problem is that does not imply definite central nervous system disease.
Thank you, sir. Sir, in a country like Pakistan, where TB is widespread, what should we look out for and how can we treat it?
Well, I think for Pakistan, and actually I would say a large part of the world, I think this is the concern with this case, whether since a lot of people are latently infected and don't know it, or they've been diagnosed, to keep in mind that the issue of COVID-19 is possibly something that's going to make TB get worse. And that maybe some of the things you are dealing with are not necessarily COVID, but actually TB. So I think clearly in high endemicity areas like Pakistan and India, I would consider TB very fast in the right population. Maybe look for evidence of TB, either a sputum study, TB skin test, however the patient presents. But I would put that at the front as a possibility if the patient is not doing well. This is I think more stuff is going to come out on this with time. People are beginning to look at this. But I don't know how often this happens, like our patient. But I have no doubt in my mind that they are happening, and just people are just not recognizing it.
Yes, sir. Quite a few cases of corona, which had typhoid as well, a lot in Pakistan as well.
Yeah, I'm sorry, I didn't hear your question.
No, I was just saying that there were quite a few cases related to typhoid and COVID as well, just like TB and COVID, particularly in third world countries like Pakistan.
Sure.
We have another question. What major biological changes occur that affect the body if a person is COVID positive? Is there some permanent damage that can occur in the future if a person recovers from COVID?
Yeah, so that's a very good question. The long-term effects are being looked at in adults, as you well know. That includes protracted fatigue, a lot of joint complaints, a lot of post-viral manifestations, a lot of CNS symptoms, a lot of cardiac problems. In children, the focus has been, because in children it was thought to be a mild disease, and it is mild for the majority. There are no studies on these patients. However, in the multisystem inflammatory syndrome associated with COVID-19, there are some slightly longer term studies with cardiac MRIs showing cardiac fibrosis and so injury to the myocardium that may persist. We have not yet seen cases of long-term disease associated with COVID-19 because this is just a young disease and there hasn't been a long enough time to follow these and know what's going to happen.
Yes, sir. Sir, if the first COVID was so severe, what do you think the second spell's severity? What do you think of that?
I'm sorry, say it again.
If the first spell of COVID was such a severe one, what do you think about the second spell of severity? What's the severity of the second spell?
Oh, the surge?
Yes,
the anticipated surge?
Yes.
Well, this is an opinion, of course. Only God can tell us what's going to happen. But I don't see it as bad. And people, at least, I don't know how it's going on in Pakistan, but in the United States, people, despite all the political turmoil, people are trying to be careful. They are wearing masks. They're using sanitizers. I think I don't think there's going to be a big second surge at all. I think it's going to be it'll increase, but I don't think it's going to go back to the way we started. But because people are doing something. Now, not everybody is, and some people don't believe it, and some people think it's a conspiracy, etc. But the fact remains, there's a lot of people. You cannot go into stores now without masking, and you cannot go into doctor's offices. You cannot go into anything without putting a mask on. And this is, at least in Michigan, is a government mandate, and people are following it largely. So I think this is how the virus spreads. I also think the virus itself will change. It's an RNA virus. RNA viruses mutate, and they mutate frequently, and eventually they will, I think, mutate into less nasty form. As I tell people, it's not in the interest of the virus to kill you, because if it kills you, it dies with you. For survival, the virus really can make you sick, but not kill you, so it can live and move on to others. So I think in the end, what's going to happen is going to slow down, like what happened with influenza H1N1, where it became now, when in 2009, every case that was positive, everybody freaked out. Now it's like, comes back positive on our swabs. It's like, oh, the patient has influenza. Nobody even thinks twice about it anymore. And I think that'll be the fate of this virus anyway. But that's all opinion. I just want to make sure your listeners understand that this is a personal opinion.
Yes, sir. Thank you, sir. Sir, what is the rate of secondary bacterial infection in COVID positive cases?
So in adults, there are reports on secondary bacterial infections, and they can be like 20% or something in that range, depending on the study. Now, these are all very sick patients in their ICUs, and a lot of times it's not clear whether this is from intubation, from complications of your management, but you can find them in a fair number. Now, in pediatrics, we are not sure. As I said, all these studies get done on sicker patients, and the sicker patients in pediatrics are fewer. If we look at the multisystem inflammatory syndrome cases that we've dealt with at Beaumont and others have dealt with, most of them don't have anything other than COVID in terms of what we can find. We do swabs for other viruses. We've been able to do it looking for alternative pathogens, but we haven't found any, at least in our population.
Yes, sir. Sir, do you think it's possible that COVID made her more susceptible to TB, or?
Oh, you mean if you have COVID,
Yes,
then
sir.
you can get TB? I think the answer to that, I don't know the answer, but I can tell you that from the animal experiments, when they co-infected the animals at the same time, so they gave them a viral illness and TB, so not COVID per se, but other viruses, that the animals could not contain the Mycobacterium tuberculosis compared to animals that were just infected with MTB. So now that's a stretch to go from some animal work to the humans, but I think if the patient is unfortunate to have COVID-19 and then exposed to somebody who is spreading TB, it might be a very bad circumstance for them, yes. But again, this is based on really a very small amount of laboratory-based data, not real-life patient data.
Okay, sir. Thank you so much. Sir, why is species negative in CSF?
Say that again.
Why is species negative in CSF?
Negative? Why is
Yes.
it negative?
Yes,
Yeah.
sir.
So the theory again, like I said, this is all new. So it's the theory is that because the receptor for the virus is not widely spread in the CNS, that maybe that's the reason why you don't see enough spillage into the spinal fluid. That's what people are thinking. Again, to be determined if this is even true, but this is the hypothesis right now.
Okay, sir. Thank you. Sir, do you think other coronaviruses also cause neurological symptoms?
The SARS, the original SARS, and MERS, the Middle East respiratory virus, which was a problem, I don't know, about 17 years ago, both have been shown to be associated with central nervous system disease. And in fact, in animal studies, shown to be neurotropic. They do hit the nervous system in experimental work. So yes, so they do, except they faded quickly from the scene and did not become the pandemic they were feared to become, as opposed to COVID-19.
Okay, sir. Sir, a participant is asking you to kindly elaborate a little about encephalopathy.
So encephalopathy is a term where you have mental status changes, maybe don't respond well to commands or conversation, and you have EEG changes of brain slowing. So no like focus of seizures, no evidence of you didn't stroke, there's no stroke, things like that. And they are generally associated with no inflammation, evidence of actual inflammation in the spinal fluid. So you do a lumbar puncture, there's no cells, there's no abnormal protein or glucose. So you clearly have nervous system symptoms that are not associated with inflammation the way we know how to measure it. Your molecular studies are negative in the spinal fluid, so you can't find any evidence of actual infection. And that can be related to cytokines released elsewhere in the body because they're going to travel through the blood. A good example of encephalopathy and neurologic complications from cytokines is in the newborn period, where sometimes chorioamnionitis and the like, because of the cytokines that are available, can increase your risk of cerebral palsy. So neurologic deficits, and that's been related to the cytokine exposure. And this is one of the things that are being studied right now for women who deliver while they are sick with COVID-19, and whether the mother's cytokine release is affecting or will affect the development of their newborns.
Yes, sir. Storm relevant to COVID-19?
You were cut off. I'm sorry.
Sorry. Yes, of course, sir. Is the cytokine storm relevant to COVID-19?
Yes, and I think your first speaker was trying to do that and discuss that before he got cut off. So hopefully he will cover that. Yes, I mean he will. I saw on the slides he's focused on that, which is quite appropriate.
Okay, sir. Thank you. Sir, another question. Could you please tell about the impact of SARS-CoV-19 on the immunity of children? Is it strengthened or weakened, and what could be the reason behind it?
I don't know the answer to that because that's not been studied. I don't know. I mean, the patients do become lymphopenic. So while they're ill, and that certainly is the type of cell that generates your antibodies. What has happened, which is not exactly answering that question, but what has happened in the United States and elsewhere is because of COVID, immunizations in general have fallen, and so people's immunity, the children's immunity to preventable diseases has declined quite a bit. And that's a concern for outbreaks. But whether or not in the end the patients are better off or worse off, I don't think anybody's looked at that. I've not seen any papers on that.
Okay, sir. Thank you. Sir, does the virus develop solid immunity against infection?
Say that again. You keep getting cut off. I'm sorry.
I'm so sorry, sir. Can you hear me now?
Yes, yes.
Does the virus corona develop solid immunity against reinfection?
So this is actually a hot topic right now, so there are papers that show that your antibody is not long-lived, that it may fade after a little while. There are cases where second infections have been documented in people who are antibody positive, and so there is evidence that people with milder disease or asymptomatic infection may generate less impressive responses. So the one thing I will warn your audience is the antibody tests. The immunity to viruses is generally mediated by lymphocytes. By cell-mediated immunity, not so much the antibodies per se. And sometimes you can lose antibodies but still be protected because you have memory T cells. So upon re-exposure, your body will generate antibodies quickly. That's called the anamnestic response. So, but that is very difficult to measure in the laboratory. What is easier to measure is actual antibodies. So the fact that you don't have antibodies does not equal no protection if you generated them before. And the other point I want to make is, as I alluded to earlier, the virus mutates frequently. So if you have antibodies and the virus now has mutated, and you get reinfected with, for us it's COVID, it's SARS-CoV-2, but you have to do genetic testing to determine whether it's really the same strain you had originally or a new strain that's in the same family but not the same virus. So a lot of that is, you cannot generalize at the moment beyond saying that it's been observed that in some the antibody response seems to stay, in others it seems to fade after a few months. And there are so far rare cases of proven second infection in patients. And I think all these scenarios will happen anyway, because it happens with influenza, it happens with RSV, it happens with a whole bunch of RSV, RNA viruses. So it's none of this is a surprise.
Yes, sir. So we have another question. Where do steroids come from a patient with moderate to severe COVID symptoms with susceptible diagnosis of tuberculosis?
So we gave steroids because I assumed that this worsening may be related to cytokines, inflammatory response. Now, whether the steroids we gave worsen things for the patient, I don't know. As you know, steroids are used in TB meningitis and some patients with increased intracranial pressure and hydrocephalus. So it's not that it's not used. Did this contribute to the patient's worsening? Possibly, yeah. I mean, I can't say no. The steroids have become very important now in the management of lung disease related to COVID-19, and in fact seem to be, like especially dexamethasone seems to be the most beneficial medication to give people with severe COVID-19 pulmonary disease, because a lot of the injury seems to be cytokine release related, and by cooling the inflammation, you might be able to salvage more of these individuals.
Okay, sir. Thank you. We have a few more questions left. Were there any cases of reactivation of TB with the patient presenting or treated with COVID symptoms?
Read it again.
Sorry. Were there any cases of reactivation of TB with patient presenting or treated with symptoms?
Not that I've seen in the literature. Yeah.
Okay. So we have another question. Is there solid evidence that leukoencephalopathy was specifically due to the COVID infection?
You mean our patient or in general?
Your patient.
So on the pathology, because the brain was very necrotic, and TB was found in pretty much most of the brain, it was not possible to distinguish that. The only thing we have is the positive cerebellar tissue PCR for SARS-CoV-2 and the fact that we saw the viral particles on EM. So there was involvement of the virus, but as I mentioned, I think the main driver of the severe disease was the TB.
Okay, sir. Sir, we have our last question. A participant wants to know why you attempted the GFAP on the patient.
Yeah. We did not attempt it per se. We sent for an autoimmunity panel on the spinal fluid. Now, at the time the patient, when this sample was sent, the TB diagnosis was not really made yet. This was made after the patient passed away. And one of the questions was, is there an autoimmune component to her worsening? Is that why she's getting worse instead of getting better? Or did she have autoimmune encephalitis and happen to get COVID? So at the time, this was sent in order to, try to understand what happened to her better. And we ended up getting, so this is a general autoimmunity panel. It wasn't a specific autoantibody we look for a whole bunch of autoantibodies. This panel is done through the Mayo Clinic, and they include quite a few autoantibodies. The only thing that came back positive was this one, and this one is not specific, but is indicative of brain injury and can be seen in like I said, encephalitis and other things. And typically, it's astrocyte damage. I think this is an antibody that got generated during the process, and I don't think it's, I think it's a consequence, not the cause of her problem.
Okay, sir, thank you. Sir, we have another question. Does the current research suggest that, number one, conclusively that SARS-CoV is causative of these neurological manifestations, and number two, to address and potentially neuropathologic sequelae of the SARS-CoV infection of the central nervous system?
So I think the fact that the nervous system is involved in COVID-19 is well established now. The question is whether the symptoms in your individual patient are due to that or not. So the patients can have, as I said, they can have central nervous system disease as a consequence of vasculitis and stroke or hemorrhaging. They can have it on the basis of inflammation, encephalitis. And so there are a whole slew of mechanisms of injuring the brain. Now, the question is, what do you do for these patients if they have neurologic symptoms, and whether they should get, say, antiviral therapy with remdesivir or steroids? And the answer to that is nobody knows what the optimal management is. Again, this is a work in progress. If a patient has neurologic symptoms as part of a bigger problem like lung disease, then I think these patients are getting steroids these days anyway. But there isn't any standard therapy that's been shown to be the way to go for anything. I mean, this is, again, those people who follow the literature will see that studies come out touting a particular therapy, and then a week later, other studies come out showing that it doesn't work. And the best example is the hydroxychloroquine azithromycin, which was all the hot rage, and then now it's highly discouraged. And remdesivir seems to help some. Steroids seems to be the thing that helps the most, but this applies to individuals with primarily lung disease and systemic symptoms, not CNS. So again, I don't have a good answer to that because there are no good answers right now. But this is there's a lot of studies going on in a lot of places. So we at Beaumont have a study on ketamine in adults that seems to help patients. So there are all sorts of naloxone. So there are all sorts of things people are trying. So I think the final word will not come for a long time.
Thank you, sir. Thank you so much, sir. This is our last question. And with your permission, I would now like to conclude the question and answer session. Thank you so much for sharing your valuable insight and taking our time all the way from the United States. This has been a wonderful learning experience for all of us.
Well, thank you for having me.
Thank you again, sir. Dr. Zaid, I would like to hand this over to you.
Thank you, Dr. Mavish and Dr. Faraj. That was an amazing case of presented. Now I'd like to introduce a second speaker for the evening, Professor Dr. Aisha Menaz. Professor Dr. Aisha Menaz is a pediatrician and medical educationist. She graduated from Dow Medical College, a premier medical college in Pakistan. She did a fellowship from College of Physicians and Surgeons of Pakistan and Masters in Health Professional Education. She has served as the head of Pediatric Department at Dow University Health Sciences and is an Associate Dean Medical Education at CPSP. Dr. Aisha is also a chairperson of COMPAL, an NGO working for children's rights and against all kinds of child abuse and maltreatment. She has extensively worked in the area of children's health and protection. Her particular areas of interest are infectious diseases, child development and learning disorders, liver and GI diseases, child protection, medical education, and research. She has published over 100 original papers, articles, and reports in reputable journals and newspapers. Professor Dr. Aisha Menaz is also a recipient of President Gold Medal Award for services to child healthcare and protection and Ashoka Award for social and entrepreneurship. I would now like to welcome Professor Dr. Aisha Menaz.
Assalamu alaikum, ma'am.
Wa alaikum assalam. Thank you, Mavish. Thank you, Zahid. I'm really humbled by your introduction, and it's an honor to be in this forum, which is a very, very important webinar. I will be discussing with you a slightly different aspect of COVID. Although the problem was there, but with the COVID and with the confinement of children within the home, there is a looming threat of child abuse. So my topic, as you already have shown in the slide, is that what child safety measures we can take during the, not only during the COVID days, but also beyond the COVID days. So without, I guess, further delay, shall we start, Mavish, if you have, you're all...
Yes, please, ma'am.
Yes, please. May I have the first slide, please?
Yes, of course.
And before I go on, I would like to thank Professor Samia also, a very dear friend of mine. My heartfelt condolence to Professor Samia for the sad demise of her husband, Professor Naeem. We all felt very bad that he had a sudden death. May Allah rest his soul in heaven. All our prayers are for Samia and his son and the family. So let's have the first slide, then we can have a discussion. Well, I will begin with this sentence. You cannot raise your children as your parents raised you, because your parents raised you for a world that no longer exists. And now we are talking about the new normal. So even prior to COVID, there was something which was called old normal, but nowadays we'll have to prepare our children for the new normal. And the safety measures is something which is very, very important. We need to consider. Next. Mavi, shall I run the slide myself, or?
Ma'am, it's up to you.
Oh, well, this is my disclosure. I don't have any relevant financial relationship, and I don't have any conflict of interest. Next.
Ma'am, it's if you want, we can run it.
Yeah, I think you should run it, because I suppose there's something problem is going on with this.
Okay.
Next. Next. I'll dedicate my talk to the memory of children who were subjected to worst form of child sexual abuse and then later on murder. And we as a nation admit that we failed to protect these innocent angels from the culprits which have led to their untimely demise. My talk is dedicated to this. Next. Yes. Okay, my presentation, I'll focus on these 4 or 5 areas of discussion. One is a little bit about digital areas and why safety of children on internet is very, very crucial, not only from our point of view as a pediatrician, but also in general, and particularly why during COVID-19 days we are so much concerned with the safety of the children. Then how children are abused online, I'll discuss few of the ways on which the children are abused online. A little bit about what need to be done and few of the recommendations which can be taken off and how to work on the child safety. So my next. All right. Digital era or new media age or a computer age, this all began around 1970s. When we were kids, the television was only introduced, but the computer age, the mobile age was not at that time. So it began its appearance around 1970s. So it's also called an information age or era, and it's a time period in which people could access information and knowledge easily at their doorstep. Gone were the days when we'll have to run to the library, we will have to run to the bookstore or a bookshop to get a requisite. Now everything is available at your palm. But this has also brought changes in our daily life, and it has reshaped our environment and society. But it has also has a lasting impact on the social, economic, and political life of our societies, and particularly it has affected our children. On one hand, it has aided in enhancing the practical, experimental, and scientific knowledge of technology. Digital era do have its merits, but somehow we are not cashing on the merit of the digital era, but rather than children are lured into worse form of abuse through the digital era. Next. During the past few decades, we have seen a rapid growth and development in the use of electronic communication and information sharing by the internet. And when I talk about internet, it means it's a global term encompassing terms like World Wide Web and cyberspace. The digital world is available, and use of digital tools to communicate on the internet is available. There are digital advices, there are smart advices, and there are other technologies, and I'm sure our youngsters are quite aware of it. Communication are done in a number of forms. It can be in the form of a text or an audio or some visual material are shown. And this is commonly accessed through email, news group, bulletin board, discussion group, chat rooms, games, etc. So there are a number of means by which these materials are displayed. Most users use the internet through ISP, which has the capacity to receive, transfer, and store large volumes of information. Globally, 1 in 3 internet user is a child in our country, globally. And the incidence is much higher outside the West. In the Southeast Asian countries, the incidence and the prevalence of internet use is much, much higher. In United Kingdom, 65% of 8 to 11-year-old children own a smartphone, and 90% of the children live in a home with internet access. 1 in 10 children is involved in texting, which we are going to discuss a little while. Grooming is an offense in United Kingdom, and it's illegal to incite a child to engage in a sexual activity. In Pakistan, there is a rising incidence of use of mobile phone. Almost 50% of our population are using mobile. More than 36% household uses internet, and there is a recent report that during the COVID days, there is a 25% increase in the use of internet, because now the most of the population were confined within their homes, so internet use has increased considerably during the COVID days. Next. Next. So digital era has brought about a change in the usual upbringing of our children. Internet can offer tremendous opportunities for innovation, entertainment, socialization, education, but somehow without supervision, the virtual world can be a dangerous place for the children, and this is what we are going to talk about in a while. Children usually enter the new digital world from the comfort of their own home, spaced, mostly unsupervised. This is somehow at least the reality which we are facing these days. Although a number of online activities have started recently, like schoolwork are being given on internet, there is a social networking online, gaming is quite commonly used, and particularly during the COVID days, children is spending as much as 10 to 12 hours of a day in these online games. And this has become a new norm for them. These activities were more popular during mandatory social isolation. As children, were kept engaged in online in various activities most of the time. So this has affected children on social level, on a cognitive level, and as well as on the emotional level. Next. But this digital age is not without its problem. Online abuse is very, very high these days. It comprises of any type of abuse that happens on the internet. Now, social media, online gaming, or mobile phones, and children and adolescents are the main victims of these online. Parents are usually busy and they are involved with the other activities. So often parents themselves introduce these online games to their children, and once they are introduced to these games, they spend most of the time. There is an increased use of digital technology which has given the child predators an easy access to lure and abuse children by various methods like cyberbullying, which we are going to discuss in a little while. So these easy availability of digital advices and smartphones is transforming our child's life in an unprecedented way. Most of the children, when they were kids, they were not exposed to these smartphones and the digital devices. And our children, being much intelligent, they sometimes try to oversmart their parents while they are using these devices. Next. So now the internet has become a very popular means of recruiting children for sexual purposes, simply because it provides an easy access to children, and it also reduces the risk of being identified as an offender. So online, most of the time offenders hide their identities, or maybe they impersonate as someone much closer to the age group of the children. So these online child predators, and we call it pedophile, has a field day now. They cleverly create and share pornographic and illegal material which is cloaked by technology. And often these children, they are more accustomed to this newer technologies, so they can be easily accessed by these pedophiles. Next. So there is a dark side of a digital era. Somehow this innovative technology has not been used to its best advantages. We are more exposed to the dark side of this digital era. The advent of internet has on one hand opened up new vistas of information, communication, and education, but has also given child predators a novel and easy way to lure and trap children into the cyber world. These young minds have little know-how about online privacy, social networking norms, and other internet safety and security issues. Unfortunately, parents and teachers provide little or no information on internet safety to their children, partly because they are busy and partly because they themselves don't know what are the internet safety measures they should adopt. And thus the popularity of internet sites for social interaction, unrestricted access to age-inappropriate content online, and extended screen time have a disastrous impact on our children's life, which we are witnessing from now on a day-to-day basis. Next. Can I have the next slide, please? So there are a number of ways by which the children are lured. They could be lured into this by cyberbullying, which is a crime in most of the country, including Pakistan. Gaming, coding, sexting, grooming is another way of luring children into this dark world. There is a global fad among the youth of taking selfies. This has led to photographs being shared on social media with no privacy setting. Selfie craze has resulted in a number of accidents and deaths among the youth. Even in Pakistan, this has led to a disastrous effect, especially when it involves the females. This has led to even to the murders of females. And it has led to suicides, murder, blackmailing, and similar heinous crimes. Online relationships through social networking websites are often fake, but the children don't know about it. And this has often resulted in untoward consequences like sexual abuse. Next. The parents need to consider certain issues when they expose their children to this cyber world. And somehow, as a parents, we are not supervising our children when they go on online. And we consider this as a benign pastime. They think that the children are now occupied, they are not going outside the home, and as a result, there is no danger of them being abused, which is a wrong concept. We provide the children with computers, laptops, smartphones, and let them serve the virtual world on their own without any supervision. They are not warning our children to understand the complexity of an online content and how they can differentiate between authentic information and the misleading content. Daily, I am seeing children at my clinic where the parents brought the children with a psychosomatic symptom, and when I asked them how much time they are spending on the internet, minimum of 10 to 12 hours they are spending on the internet, on games, on chatting, and the parents are busy with their own. So they are leaving their children in the hands of child predators to be exploited to no limit, which they are not realizing. The exploitation of young people on the social media is a growing phenomena, and it is underreported due to social taboos. Next. If you look in the international scenario, there are a number of studies on child sexual abuse on internet. Quarter of our children, according to these studies, are solicited for sexual purposes, and they reported they are being extremely upset or afraid. So they are developing a number of psychosomatic symptoms. Younger children are reporting a greater adverse effect, according to one study. There is another Australian survey done on adults. They reported a similar finding, and this has been published in a NetScan. Only quarter of the children who had been sexually solicited told their parents, and therefore no reports were made to the police. 1/3 of the children did not even disclose the solicitation. Number of studies have supported the view that children often keep such cyber friendship a secret from the parent and sometimes from the friends as well. One Australian Broadcasting Authority study showed that children exposure to a broad range of offensive material on the internet using a sample of 310 internet using household with at least one child less than age of 8, and it showed with consistency that only 45% children were exposed to undesired internet content and had reported its experience to a parent. Excuse me. Next. Thus, child sexual abuse is a widely prevalent and very, very serious problem. In USA, 19% of children, according to one study aged 10 to 17 years of age, who regularly use internet, reported being approached for only sexual purposes through the internet. 1 in 7 of these children reported that the offender also attempted to contact them by telephone or by post. The same Australian survey I was talking about, which has done a survey on the adolescent, 27% of the children had been contacted by the predators for sexual purposes. There was one study done in Pakistan. This was about 2 decades back, which is in 2002. At that time, internet was not that much of use, but there was internet clubs, which has sprouted like a mushroom all over the cities, and this has shown with impressive consistency that exposure to pornographic material at nightclubs has cast a negative effect on, especially on the attitude towards women. Next. Next. So talking about the same study, this team, and I was part of that team, we surveyed about 15 internet cafe in Karachi, Lahore, and Peshawar. And according to this this study, children were visiting these internet, they belonging to the lower or middle class families because the well-to-do had computer in those days, and they were between 12 to 18 years of age, and more than 70% of these children who were visiting these internet cafe were visiting the pornographic sites, or they were watching seductive films or over suggestive songs. Very few of these children use the internet cafe for sending or receiving email for education purposes. 30% of the children whom we interviewed during this study, they admitted that they visited the internet clubs without their parents' knowledge. That same research, which has been published as well, also established that 50% of the sex offenders used pornographic material and had behavioral problems. Crime rates are 4 times higher in areas where sex-oriented business functions, because one thing leads to another, and it is no surprise that we are getting a lot of very young sexual offenders. Maybe many of them were exposed in their childhood to these pornographic materials. Next. Although no child is exempt and no adolescent is risk-free, but sexual offenders often target the children who are particularly at risk. Few of the characteristics of the children who are more likely to be targeted are those children who are living in an institution like hostel or dormitory, children who have experienced maltreatment within the house or within the education institute, children who are emotionally immature, children who have got learning or social difficulties, children who have problem with peer friendship, or children who are deprived of love or attention, children who have a strong respect. There are some households where a lot is expected from a children, and they are too ritualistic and too strict when it comes to disciplining the children. So they try to run away from this strict disciplining action, and they try to seek friendship outside their house. Children from single families or single parent families are also more likely to be targeted by these offenders. And of course, children who will cooperate for a desired work, because often they lure the children with money or some gifts or a present or some computer games. Next. There are a number of ways by which child can be sexually abused online. Few very common mode of abusing children are grooming, live streaming, consuming child sexual abuse material, coercing and blackmailing children for sexual purpose, or sexting. I will describe few of it so that you will understand to what extent these predators can go to lure children to their heinous profession. Okay, next. Let's start with grooming. This is a very, very commonly used way of luring children towards the sexual offense by the predators. The predators are usually very intelligent people. They have a very gradual process of drawing the children towards their sexual relationship. They initially target the children. The offender first target a victim by sizing up the child's vulnerability, like children who are emotionally withdrawn or have little parental oversight or who are isolated, who have lower self-esteem or self-confidence. They are easy prey to these predators. Once they have targeted the victim, the next stage they try to gain the trust of the victim. And this they gain by watching and gathering more and more information about the child, getting to know his or her needs and how to fill them. Sex offenders mix effortlessly with children by generating warmth and calibrated attention and become an online trusted friend. And in this time, they often give wrong information about their age, about the picture they are sharing are also fake. So children think that now they have got a very trusted friend across the uh, cyberspace. After they have gained the trust of them, the next is the filling the need. Once the child offender begins to fill the child's need, they may gain more importance in child life and may become idealized. They give extra attention to the child. At times, they also give them special gifts and gain personal importance in their life. And all the time, they keep on telling the child to keep it as a secret, the friendship as a secret thing. Next. The next stage, once they have gained the trust and when they have the child now very much in their sphere, they try to isolate the child. They spend more time alone with the child. They develop special relationship with the child. Child may also feel closer to the offender than their own parents, and gradually secret elements in their relationship begins to develop. And once the secret elements begin to develop in the relationship, the next step is sexualizing the relationship. The offender gains confidence and emotional dependence of a child. Progressive sexualized relationship develops. They start sexting, which is a mixture of sex and text, and gradually they try to desensitize the child towards the sexual touch. And this desensitization even occurred through the cyberspace by talking, by taking and using pictures, even creating situations. Like the offender might tell the child that the two of us are all alone in a swimming pool. And then they started using sexting material. Offender also take the advantage of child's natural curiosity, using feeling of stimulation to advance the sexuality of the relationship. So you see, they have got a very systemized, progressive, and in a very patient way, they try to trap the child in their snare. And once they have gone through all these steps, now they have the control of the child. Once the abuse is ongoing, offender use secrecy and blame to maintain the child's continued participation in silence, mainly to prevent child. And if the offender happens to be living in the same city, after that they begin to meet a child physically in a place, in an isolated place. Next. So this was about the grooming. The other very, very common way of alluring the child is cyberbullying, which is prevalent all across the globe. Cyberbullying can take a various form, like repeatedly writing hateful things, sending mean email and text messages, spreading rumors or gossip about the child or the adolescents. They do make fun of someone on chat where there are multiple people, so they start making fun of it, ridiculing them, asking threatening or comment section, pressure someone to send sexual images, rape culture. This is a targeted attempt at mocking and threatening an individual, resulting in emotional abuse of the child, commenting on their public posts, often as a result of disliking someone or wishing to shut down. So this had led to severe degree of emotional abuse, and often it has driven a child to as far as committing suicide. So cyberbullying is not without its untoward effect, and it's one of the very, very worst form of sexual abuse online. The other form is next, sexting. As I've said earlier, that it's a combination of sex and text. Sexting is a process of sending sexual images or videos or text. It may also involve live chat with someone on webcam involving sexual act. Sexting without consent is a form of sexual harassment. And here I would like to emphasize that when it comes to children, that is any individual who is 18 years or below, consent has no importance itself, because such a child, even he or she gives consent, has no legal or moral standing. So children often receive unsolicited sexual messages through social media or email from strangers. Sometimes children are pressurized by adults or by other young people to get involved into sexting, often using pornographic material. So they often ask the children to share pornographic material, or sometimes they forces children to expose themselves in an untoward manner. Next. Next. The children are also coerced and threatened in a number of other ways, and which is very, very common on these sites. They can be pressured into sexting, which we have already discussed. They may also blackmail children into keeping the sexual abuse a secret, and by saying that the children himself will be blamed if they reveal the secret, or they will send sexually explicit photographs of the victim to the family of the friend. And this has been occurring particularly with quite consistency in Pakistan as well, that often children are blackmailed by these sexual offenders, that they will send the photographs or they will send their texts to the family, and often this crime goes on until it is too late for the child. Next. The other way we can, the children can be bullied, the children can be sexually abused is by games. Sexual offenders sometimes seek out children to abuse via gaming platforms. There are a number of video games which are present here. These platforms enable the gamers from all over the world to communicate with each other while playing. These video games are proving as an hunting ground for sexual predators. Children are often blackmailed this side. Recently, there was an online game, PUBG, which is reportedly claimed the life of a number of teenage boys and children. 2 children have committed suicide also by playing these games, because these games put so much pressure and so much stress on the child, and by giving them challenges that often, if they are not able to meet the challenge, they try to take their life. So boys committed suicide by hanging themselves in these two, and this has been going on during the COVID times. And many of you are aware about the Blue Whale Challenge, another online game. This was reported earlier. This was an online suicide game aimed at teenagers that was alleged to be linked to numerous deaths around the world. So this has been happening in this world, and there is a rising incidence of these during the COVID times as well. Next. Many of you are also aware of the dark web. It's not a publicly visible part of the internet. It's generally accessed using dedicated software like Tor browser. The Tor browsers, for many of you who don't know what Tor browser is, it's block other browsers and plugins such as Flash, Realtime, QuickTime, etc. And they can be manipulated into revealing your IP address as well. And why it is so dangerous? It makes it very difficult to detect someone's identity on the dark web. The children are then often lured or pressurized into illegal activity like drugs or arms trafficking. This can be a site for sexual offenders to form communities, for example, Dark Scandal, which is another website on the dark web posted and distributed videos and images featuring. So we have entered a very, very dark world with the advent of this digital era. Next. So now, with the COVID, which has been the advent of COVID pandemic, this has been going on for the last 6 or 7 months or so, and we don't see an end to COVID time in the recent future. So it has become all the more important that we should look after the child's safety. There are a number of reasons why we are so much worried about child safety during COVID time. Children are spending more time at home. It's virtual social isolation, because there is no physical contact of children with their peers. Physical interaction, social activities like outing, picnic, etc. is reduced. There is a fear of contracting disease and transmission of children to the family. The family is always under stress. This, together with hospitalization of the affected adults and isolation, has further pushed the child to isolation. Death of the family has also um, uh, added a lot of stress to the parents, and once the parents are under stress, they try to take it out to the children, and children will find an escape in the dark, in the digital web. So there is also an information overload. There is an overload of treatment, what drugs to use, what are the drug abuses, a number of home remedies are on the line. There is a number of conspiracy theories going on. There is an economic crisis going on, unemployment. A number of individuals are working from home. In Pakistan, there is a frequent power breakdown, load shedding. All these have added to the stress of the parents, and this stress has been taken out by to the children. Next. May I have the next one? So, adding to these stresses, the kids are not only exposed to the stress to which their parents are exposed, they are now increasing more and more time on the internet. Schools are closed, their online education is going on, but most of these education also have got a less secure education application. So a child who is lonely and isolated, has mental health problems, they become an easier target of the child abuser. Parents' supervision is not available most of the time because of their own workload, because of the illnesses in the family, because of the other health problems. So most of the time, they are often neglecting the needs of the children, and this is not willful neglect, but because they are too pressurized. Teenagers these days have nothing to do, but they indulge in risky behaviors, and they are trying to exchange explicit material which often go into the wrong. The predators really have a field day these days, and their activities has increased during these days. And the stress in parents has led to anxiety, depression, panic attacks. There is an increase in domestic violence which has been noticed during the COVID days, including the spouse abuse, and the children are now witnessing everything because they are now spending more time at home. The yelling, shouting, and admonishing children, which is going on in most of the houses, has led to psychological trauma to the children. There are cases of children spanking has led to this. The children nutritional and emotional and educational neglect is also adding to the risk of children exposure to the digital website. There is also a report of gender-based violences which has been reported. Uh, we as a child rights activist, we fear that there may be going to be early child marriages because the parents are too much under stress, and they would like to take out their stress towards those who uh, uh, can have an easy compliance to their demand. Next. So during the COVID pandemic, this child safety needs immediate attention. During lockdown and during out of school, they have no access to group activities, team sports, or playground activities. Parents or caregivers are not able to work, and there is no clarity on how long the situation will last. And this is very important. We really don't know for how long this pandemic situation is last. So there we have no answer to this. And when the children ask these questions, we are absolutely clueless what to tell them. Keeping these children busy and safe at home is a very, very daunting task for the children, particularly in household which have low income group or a crowded household. The challenges are highlighted. Children turn towards the parents for support, but they receive no comforting or positive signal. As a result, the home atmosphere is emotionally charged these days, causing severe emotional trauma and even physical abuse to the child. As I've said, that there is a report of increase in domestic violences which the child is witnessing on a daily basis. Reporting of such incidents has also increased, which was very previously. Many of these incidences was very, very poor. Although in pandemic it has reduced, but nowadays we are seeing an increasing number of cases of child abuse that is being reported in the electronic and the print media. Next. I think there are just... And this has been confirmed by the increase in the cybercrime which has been reported during crime, and this has been reported by Cybercrime Wing of FIA Pakistan, has made an advisory for parents and children during the corona epidemic. The Digital Right Foundation Pakistan has also reported a 189% increase in complaint on its cybernet harassment and helpline. Europol has also has reported an increase in online activity by those predators who seek child sexual abuse material. There is a National Center for Missing and Exploiting Children in USA, which has received 4.2 million reports in April and up to 2 million reports from March 2020, at 106% increase from 2019 onward. So child abusers have created and shared an online grooming manual which describes ways to manipulate and exploit the increasing number of children at home. So while we are working on the safety of these children, the child abusers are also not sitting silent, and they have newer ways of luring children to their heinous crime. Next. A few words before I wind up my talk: how parents can protect children from the online abuse. A few of the tips I would like to share with those of us who are the parents or teachers or caretakers of the children, and what they can do at this stage. May I have the next one? Next slide. Parents and caretakers should talk to the children about the online safety. Even if you are not very well versed with these digital technologies, you'll have to become aware of these digital technology, and you'll have to increase your own knowledge and your information so you can talk about children about the online safety. You should explore the website, the social medias, the games, and the other apps together with the child so that you will also come to know that what is going on these websites. You'll have to talk to your teen about how to report inappropriate. In fact, your teenagers should be part of the team with whom you can sit and explore these websites. There are programs like Common Sense Media, which has got a great advice for apps, game, and entertainment for different ages. So the parents should visit these websites and get familiar with these apps or games and entertainment for different ages. There are certain parental control and safety search browser, which is strict private setting. So these private settings should be installed on the computer which is being used by the children. You should involve your children on the use of technology, and you must communicate with them, give them positive support, and be alert for any behavioral changes which you notice in your children lately. Next. Hello. You have to involve children and teen in creating family tech agreement. You'll have to sit with your child and make a technology agreement, the number of hours the children are supposed to watch TV or a smartphone. That is, a screen time has to be decided beforehand. You will have to create an advice-free spaces and time in your house, like set up a timetable for eating, playing, schoolwork, and sleeping. Help your child learn how to keep and safeguard personal information private, especially from strangers. This is very, very important, because some people are not what they say they are, and you'll have to keep on telling the children that those who are appearing on your screen may not be the one they try to post. Remind your children that the information shared on online stay there, even if you have deleted from your computer, whatever you have shared, stay there. Actively supervise children's time online, including computers, smartphones, and the tablets, whatever gadget the child is using. Next. Next. The key to communicating with the child is that you must keep the communication open. Tell your child that if they experience something online that makes them feel upset, uncomfortable, or scared, they can talk to you, and you will not get mad or punished. This communication should be two-way, and you must keep on communicating. You spend some quality time with your child, which is very, very important. Be alert to the sign of distress. You notice if your child is being withdrawn, being upset, has become very, very aggressive lately, have become unduly withdrawn lately. These are the signs which you should make you suspect what's going on with your child. You have to create a trusting relationship so that the child will not look for relationship outside their house. And every child is unique, and you may use different way to communicate with them. You'll have to adjust your message for your child needs. From children with learning disabilities, now this is a totally another group of children who needs a very, very vigorous attention and very close attention. And they may require information to be imparted to them in a very, very simple form, unlike the children with whom sometimes you can talk in technical language depending upon their awareness about these websites and about this technology. Next. May I have the next one? Now, talking about the screen time I was in, you'll have to limit the screen time. The standard recommendation for use of screen time, if a child is 2 years or under 2 years of age, avoid media totally. I have seen very, very small children, about 1 year of age, they have been given a smartphone just to play away. This is not the age where they should be exposed to any of the screen, be it a computer screen or a mobile screen. This is an absolutely no-no for a children who are under a year of age for reason other than being used as a cyberbullying or because of child abuse. It is detrimental to their mental health. For children who are going to the school, for preschool, no more than 1 hour of high quality program per day. And when I said about talk about any screen time, that means all the screen, whether it's a computer screen or whether it is a television screen or whether it is a laptop screen. Older children, high schoolers or teens, you must not let media displace other important activities like quality sleep, regular exercise, family meals. So you should have an unplugged downtime and make it sure you sit with them and draw up a chart, some agreement with them that this is what we are going to follow, and each one of you will have to follow that schedule which is set up with your teenage or your high school. And at all age, be a media mentor and co-be media with your kids. If you are sitting with your kids and you are going to all these websites together with your kids, you will be knowing what your kids are absorbed in, and maybe you will be guiding your kids towards a better and more informative website. Next. Next. So in order to summarize, finally, you must understand the digital technology, WhatsApp devices, other social, you'll have to become well versed with these technology. You have to become a technology aware person. Discuss with your child about cyberbullying and tell them what to do if they experience cyberbullying, and be aware of the cyberbullying reporting system in your areas. In Pakistan, I have shared few of the website where you can report cyberbullying. Keep track of any red flag child behavior, any behavior which you have noticed recently in the child. It should be looked upon, and it's always better to seek a help of somebody who is a professional in this field. Keep communicating with your child and make your children feel safe and have them know that they can always talk to you. And I cannot underemphasize or overemphasize the importance of keeping the communication. The more you communicate with the child, the better off your child. And your availability for them should be constant and all the time. Next. Well, these are the various resources, and maybe later on you can have an access to these. I suppose this will be available on YouTube, so you can always have an access to these websites where you can report if you are for further information as well as if you want to report it. Next. I will not go into the detail of it. This will be available on YouTube. Same in case there are helplines available in Pakistan. You can always log into these helplines, and if you report any cyber bullying or any of the crime that has been committed, or for information as well, you can log on to WHO, UNICEF or CDC website, where you can get a lot of information about the cybercrime. Next. So finally, a few recommendations for those who can take it forward. The state and society need to support children to protect children and youth online through effective policies and plan of action. Pakistan is also a signatory of Child Rights Convention, which was signed in 1990. And according to this convention, there are three important stakeholders. Of course, number one is the state. The second important stakeholders are parents, and the third important stakeholders are society. So in that order, everybody has to play his or her role. The federal and provincial government must make sure that online child protection is included and budgeted in COVID-19 response plan and beyond COVID time. The government should also scale up the scope and coverage of education TV channel and online education for health till such time we have the COVID going on. The government, information technology and social networking platforms should join forces to keep children and young people safe online, and they are the one they can counteract the predators by giving more and more information about the online safety. Enhancing safety features and new tools to help parents and educators teach their children how to use the internet safety is important, and we all need to become aware of these safety features. There are low teach solutions and should also be put in place to reach the furthest behind. So those with whom who are not on internet, but they are visiting the other net clubs, etc., they should also be taken into fold and should be informed about this. Next. School curricula, and I think this is time that we need to revisit the school curricula, and we should include the violence preventive measures, including online crimes, and this should be a part of a school curricula because now we have entered a new world and a new normal. The school curricula should provide psychosocial support and social and emotional learning activities. Perhaps the teacher's curriculum should have all these available, and they should also learn how to create safe learning environment within the premises. There are safeguarding policies to reflect the new realities for children learning from home and ensure that they can have a continued access to any of the school-based counseling and other support services. The school need to provide practical support to parents and caregivers to promote positive parenting. This is very, very important. The parents need to have an access to these positive parenting materials so that they can self-educate themselves. There are a number of projects going on at enhancing the parenting capacities, and even if they are not a part of these projects, they can always have access to these positive parenting facilities, which is available online, and there are a number of websites which can enhance their knowledge. Next. I think. Now, having said all this, now remember one thing, your children are created for another generation. So do not force your children to behave like you, for surely they have been created for a time which is different to yours. So you will have to learn their ways of learning rather than expecting them to understand and learn your way of learning. There are new modalities of learning available. So the parents, the teachers, the child care takers need to learn these modalities of learning so that they can effectively communicate with their children depending upon their needs. And finally, next. May I have the last, I suppose? Yeah, I think this was the last one. So if there are any questions, I'm too glad to answer this question. And thank you so much for your patient listening. May I have the last one, please? The next one. Okay.
Thank you so much, ma'am. That was a very informative and a very interesting session. With your permission, I would like to ask some questions. I would actually let Dr. Zaid ask those questions.
Okay. Ji Zaid.
Thank you, ma'am. So the first question is, what are Pakistan's laws related to child abuse when it comes to the internet and generally in an online forum?
Zaid, I can't hear you. Mevish, can you repeat it? Because I can hear your voice rather. What
Okay,
are
ma'am,
Pakistan? Yeah, maybe you
What
can
are,
write it down. I'm also looking at the chat rooms.
okay, ma'am, I could repeat it, no worries. What are Pakistan's laws related to child abuse when it comes to the internet?
Okay. The PEMBRA has introduced a number of new laws, and the internet laws have been Pakistan Pediatric Association, the child right groups are in contact with them. We have at some time back the internet laws, which was supposed to be uh, used at free will at all the places. Recently, we have got a number of communication with the Pakistan Telecommunication, and Pakistan Child Right Group is working on that about these laws. The cyber laws are in action, and this has been and now the if any crime has been committed and if there are any uh, information, I have shared one slide where all the Pakistan cyber laws and FIAs and the crime reporting mechanism have been developed. So these are, but very few parents are aware of these, and that the need is that these laws and these site has to be communicated with the parents and with the laymen, so that if they come across such a crime, they should be able to separate. Helpline have been established in a number of places. Health and education now have become a provincial matter. In Sindh, I can say that there are helpline that has been established where crime can be reported. The cyber crime can always be reported, and their number has also been shared. The helpline of the reporting the cyber crime is also there, but parents need to become aware of it, and these are all available on the website. So perhaps if they can go on later on to this talk, they will get all these information.
Thank you so much, ma'am. There's another question. How difficult is it to catch and prosecute the perpetrators in Pakistan? Furthermore, are there any examples?
Well, perpetrators have been caught. If we talk about the digital crime is something Pakistan has entered the technology almost 2-3 decades back, but the cyber crime wing has recently started working to its full force, and it all depends how good. Recently, there was a report of cyberbullying, and this the video went viral, and finally the perpetrator was caught because he was actually threatening an adolescent female with videos, and he also was threatening to kill that woman, the young girl. So it all depends that how consistently we have been reporting these cyber crimes to the concerned authorities, and how efficiently the entire mechanism will work. But we are working on it. A number of culprit has been caught, but a lot more has to be done. Whatever has been done is simply very meager as compared to the enormity of the problem which is present here.
Thank you so much, ma'am. Ma'am, there's another question. In your opinion, is there a significant risk for those children who are victims of online child abuse to become child abusers when they grow up?
This is a well-known fact. The children who have been abused when they were children, and if they went unchecked, then once they grow up, they often become the offenders themselves. There was some time back, about I think 5-6 years back in Kasur, there were 200 children who were found to be sexually abused, and when the perpetrators and the offenders have been caught, many of them were found to be abused when they were children. And once they grew up, they have become an offender themselves. So this is a well-known problem, and that is same is true with the cybercrime as well. Because if the cybercrime will go unchecked, many of the children who have been abused are more likelihood of becoming the offender themselves. So this is a global studies have been done, and this has been proven number of times. The children who have been abused in their early childhood, they have every likelihood of them becoming a child abusers when they grew up.
Okay, ma'am. Thank you so much. Ma'am, another question. Is there any particular gender and age group which is more vulnerable to online child abuse in this new digital age?
No age group is exempt, but when it comes to digital age, obviously the school-going children are more exposed to it. Those who have an access to the laptop or a smartphone, and those who have got a know-how about the use of these, they are more likely to be used. But teenagers are far more likely to be abused than school-going children. Fortunately, very small children are less likely to be abused unless and until they have been exposed to these material by their older siblings. In that case, yes, but digital or online abuse is more common in teenagers and younger adolescents. And
Okay,
no age
ma'am.
is exempt and no sex is exempt. As far as age is an exempt, but no sex is exempt. Both male and females are equally abused.
Okay, ma'am. Ma'am, how should parents talk to pre-teenagers and teenagers about puberty? Should they discuss physical relationships or sex education or not?
When it comes to sex education, there is a lot of phobias in the minds of many of us that they should not be talking about the sex. When we talk about sex, it does not mean that you will give actual information. It is the warning sign, and it has to be age related and the understanding of a child. Very, very small child, when you are teaching them about the different parts of the body, when you are teaching them that what are the parts which are very sensitive part of the body, you can also tell them that you should not allow anyone to touch those parts, and they should always run to you if they are touching that part. In an older children, perhaps you should tell them to shout and cry, and tell them that outside the house, even if that person is known to them, even if there's somebody with whom they are quite familiar with them, if they are making an improper gesture, if they are touching you in an improper way, or for any reason, if you bad about it, you will come to them. And at the same time, I will tell parents that please be sensitive to the child. If the child is avoiding a certain person, if the child does not want to go there, if the child did not want to visit some places, think about it, that why that particular child is avoiding that person or avoiding that place and avoiding that circumstances. You will have to think about it. Nearly daily basis we come across cases of child sexual abuse where the parents tell the child to go to the nearby shop or to the nearby places to buy something, and the child is abused. So for heaven's sake, this is a dangerous area. We are not living in an area where you can trust your neighborhood. Don't trust anyone when it comes to any small child. And yes, in an older children who are entering their adolescence, who are entering their puberty, you will have to sit with them. You will have to tell them that all the changes in their reproductive life they are going to face, and tell them in a very point of view, in a very plain manner, that these are the changes gradually you are going to experience it. This is the area where you should be very, very sensitive about it. People, if they are like trying to talk to you about they are passing session, very few people know that sexual comments inappropriate to the age and sexual psychosocial development of a child is also sexual abuse. Sexual abuse is not only coming in contact. If you are passing a sexual comment, if you are making a gesture, if you are sharing pornographic material, that is also sexual abuse, and there is a crime for it as well, and there is a punishment for it as well. So it depends on the age of the child, his sexual and his psycho emotional maturity, and you decide when in the course of their development you will have to sit with them and talk to them. But do tell them about safety at different ages, which is very, very important, and listen to them and communicate with them. I cannot overemphasize the importance of communicating with your children. It's very important.
Thank you, ma'am. Ma'am, in that case, how should parents make their children comfortable enough to discuss everything with them openly?
Look, if they are talking to the children in a matter of fact way, like I said, if a child is preschool, you do teach them about the different parts of the body. Don't you tell them that this is your nose, this is your eyes, and in front of this stranger, you can tell your aunt, uncle or aunt, where is your nose, where is that. At the same time, you can tell them that these are the areas which we should not be exposed. Even if somebody asks you to expose this, you should know. You should say no. There are a number of videos now available about the good touch and bad touch. You can show these. If you are not able to verbalize your message, maybe you can show these videos to them that this is what is good touch, this is what is bad touch, and you should also listen to them. You should make shout. In an older children, tell them to shout, to scream if something which you don't like. Even I'm not saying that maybe the gesture is purely or exclusively a sexual comments or a sexual gesture. Anything which is not like, somehow the God has placed some sensor in children that they are very sensitive to the good touch and the bad touch. Unless and until you sit to them and gradually you will tell them that these are the things which are going to happen. These are the areas which you should not be going. And do not let your children go alone in any of these places. I'm not saying to unnecessary get paranoid about it, but there are areas which are certainly not safe for the children to be left alone. Like, for instance, in a parking lot, like, for instance, in a park, like, for instance, in a mall. I've seen a number of parents, especially the mothers, they are roaming around and the children are going in some other direction. Even if they are in the play areas in a parking lot, stand with them and don't leave them with any of the attendants which are usually roaming around in these play areas.
Ma'am, even suppose regardless of what the parents try, if the child is still not very comfortable and not old enough to actually tell someone about it, what are the other ways that they can go about it? How can they let someone know? How can they post a complaint about it?
I'm sorry, Ravish, can you repeat your question?
Yes, of course. Ma'am, even if the parents tried involving the children and trying to make them talk openly about it, but they're still young and they're not old enough to actually file a complaint officially by going to the office or anything like that, but they're also not comfortable discussing it with parents, how do they deal with it? How can they go about this?
As I've said earlier, the parents need to become very sensitive to any change in the child. And if they notice any change, even if they don't understand why this change is, they should always seek a professional help. Only last week, a child is brought to me. The parents' main complaint was the child is not eating well. And true to their word, the child was about 10 years of age and he weighs only about 20 kg. And the parents said that recently the child has become very, very aggressive. The child is losing his interest, is picking up fight. And this was not there previously, but has happened. So I probed further into the history that what is the routine of the child, for how long the child is spending time with their sibs, is he using a laptop or a computer, for how long the child is using. And I was really astonished when when the mother told me that he is spending more than 12 hours on these video games on PUBG, etc. So if a child is spending 10 hours or more, how do you expect this child to spend time with other healthy activity like eating, like talking to the peers, like exercise, like playing? I I understand that during the COVID time, it is very, very difficult to allow a child to go outside, but you'll have to create activity which will occupy a child's mind and will take the child away from it. And again, I will say you'll have to limit the screen time of the child. Take, even if you have one internet, you can block the internet sources so that the child will not have an access for 12 hours. There was another case where the children were not sleeping till 4 o'clock in the morning because they were actually on the internet. And the parents thought that since the children are at home, they are not going out, they are safe at home. They are not actually safe at home. With this cyber world, they are actually exposed to a far more dangerous world which they cannot even think.
Yes, ma'am. Precisely. Thank you so much, ma'am. We have another question. Has there been any study done on the long-term psychological impact on child abuse? What psychiatric problems may it cause in adulthood?
If you're talking to me in general, yes, there are an immediate impact and there is a long-term impact of child abuse. A number of these are emotional because these children, the longer the child abuse, the more devastating is the long-term effect. Because once if the child is abused once, it is easier to rehabilitate the child back to normal. But if the child was repeatedly abused for a prolonged period of time, then the emotional scarring is so much and the post-traumatic stress disorder is so much that it takes difficult. Like one of a child which we have been following for the last 15 or 16 years of age. Now the child is adult, she is married as well, but still she has problem with the in-laws, with her domestic issues. She has problem with the child rearing. She has a problem with maintaining a good relationship with the in-law. And we are listening the parents are the in-laws are all the time complaining about it, but somehow the child is still not settled. So this is a long-term complaint. Then psychosomatic complaints keep on coming. There are a lot of emotional setback to these children. Somehow integrating them back to the social and back to the cultural environment at time becomes very, very difficult to these children. So it all depends upon the child's own psyche and all vulnerability. There are certain children who are more vulnerable to these abuse. Then there are certain children who get a positive reinforcement and a positive support from their environment and from the parent. For them, it is easier to recover from them. And many of them are very now strong supporters of child rights organizations who have been abused in their early childhood.
That's great, ma'am. Thank you so much. So, ma'am, compared to the rest of the world, how prevalent is child abuse in Pakistan? And do you think it's more common online or in Pakistan, in person in Pakistan?
In Pakistan, child abuse is present in all its forms. Online, Pakistan online internet users are only 50% and only 36% have got the high score. In recent COVID, the online abuse has increased, but overall, the actual abuse physically is far more than actually it is reported. And every year it is going increasingly reported. Only last year, in the 6-month period, more than 2,000 cases of child sexual abuse has been reported in a 7-month period. And whatever is reported only represent the tip of the iceberg, because many of the time this is not a talked about issue. Often that the parents, they themselves hide the crime, they do not take it, and then somehow our reporting mechanism is not developed. So we don't have a very standard operative reporting mechanism where you can walk into the center and report it. You'll have to go through the law enforcing authority, you'll have to report to the police, you'll have to get an FIR done. So you have to go through a lot of rigmarole, and at time the parents get fed up with all these. So we need to work on it, because unless and until we have got a mandatory reporting system, which is in easy access to all, that anybody can walk into the thana or into the center and report it, and then the strict and rigorous punishment of the perpetrator is must. Unless and until this has been done, then the crime will go unchecked.
That's true, ma'am. Thank you so much. Ma'am, related to that, the abuse of underage helpers working in different houses in Pakistan during COVID, what would you say about that?
You mean talking about domestic child labor?
Yes, sir.
Are you talking about domestic child labor?
Yes, ma'am.
Somehow the crime against these is domestic child labor is, and there is no record of it as well. We have got the children who are working in the factories. There are more than 12 million children who are working in the factories. But those children who are working in there as a domestic worker in household, there is so much crime committed on them, which has been only the worst type came into the medias, and we come to know about it. But in many of these household, children as young as about 6 to 7 years old are kept as a domestic worker or helper, and they have been exposed to all sides of crime. They are also exposed to health neglect, education neglect. They are not going to school, their nutritional need are not met with, their emotional need are not met. Many of the parents just leave them to the household for months, and they don't even come back and inquire about them. So this is something which is has to be taken care of, and I think there should be a law where any child who is less than at 18 years of age should not be allowed to work in any household as a domestic worker. So we are also working on that from our organization platform and from our own NGO platform, that these domestic child worker should have been in the first place, they should not be employed, and those who are employing it, action should be taken against those employers.
Okay, ma'am. Thank you so much. Ma'am, this question is a little off topic, but the participant said that they couldn't find the mandated reporting in Pakistan in cases of child abuse, and there's not much information available to Pakistani practitioners either. So if you could shed some light on that, please.
As far as mandatory reporting is concerned, there is still, as I've said earlier, there is no standard operative procedure up till now. Ever since health has become a provincial matter, different provinces have different mandatory reporting mechanism. Punjab has got a Punjab Bureau which is taking care of it. In Sindh, the Social Welfare Department is taking, and they have a helpline as well, and they also are working on the mandatory reporter. Still, there are a lot of hitches which is there, but as such, at a national level, there is not single one mandatory. There are a number of helplines which there. There is a police helpline, there is a cybercrime helpline which is available. Actually, a layman don't have an access to it and have little information about it. So we will have to look for it. And those who have some information, they are bound to provide these information to those who do not have it. But I think the most important should be the law enforcing authorities. They should have a helpline which is dedicated and open to all, so that anybody can pick up the phone and report to them. Recently, the people have become very vocal. They have started reporting it, but mostly the time when it is too late, when the crime has been committed. Ideally, they should be reporting it much before the crime. Even if they are suspecting some abuse going on, they should report
Okay, ma'am. Thank you. Ma'am, this question is also kind of related to that. The question is about suspicious cases presenting to clinics and physical or sexual abuse for practitioners when family do not wish to report them because that person was told that by an NGO that there wasn't much to do. So they want you to shed some light on that as well.
Suspected cases have been reported. In fact, we have been organizing workshop for healthcare providers that how they can early pick up a child who has been abused. There are indicators in the child, there are indicators in the parents, uh, uh, and which can help you suspect that this could be a case of child abuse. Obviously, they first have to rule out the organic causes, and if they are suspecting child abuse, they will have to seek help of the other professional, like if the help of a psychologist or a psychiatrist who have been trained on it. And if they are suspecting sexual abuse, perhaps they could take help of their other colleague. You need to develop a team who can together work on a suspicious cases of it. We have developed hospital child protections committees in a number of hospitals. In Sindh, we have made an hospital child protection committee. In Punjab, they have an hospital where the hospital professionals have been uh, involved in a committee where if a suspected case of child abuse is candidate, we have also laid down an standard procedure that the history has to be taken. A trained healthcare provider who has been trained in early detection of child abuse and neglect will further interview the child, asking questions. Then he or she will involve the other members of the committee, like a psychologist or psychiatrist or a pediatrician, who can do a detailed examination, gynecologist if they are suspecting some sexual abuse going on. The, the parents has to be involved as a team member, and they should all sit together and try to find out and verify the fact of whether actually the abuse has been going on itself. All the time keeping a high index of suspicion that this might be occurring and it's going on itself. Child himself or herself will give a number of clues that will make you decide this style. And at the same time, you'll have to play safe that unnecessarily you are not going to blame it. So if there are any other comorbid problem, that comorbid problem has to be taken care of in order to gain confidence of the parents, etc. And once the suspicion is strong, you will have to involve the other team members like medical legal team, police surgeons, or maybe a lawyer if the parents would like to take an action against the perpetrator. Then perhaps the law enforcing authorities and the lawyers have. So you have to build up a team at various levels. At hospital level, we have started building up a team of hospital child protection committee, but we need to have a similar team at the school level and at the community level. So the child, if once suspected, it should lead to getting hold of the culprit and showing him the jail.
Okay, ma'am. Thank you so much. Ma'am, there's another question. What should a person or a parent do when a child has been exposed to pornography extensively, especially children who are under the age of 11, perhaps reaching before puberty?
One thing, if the child is exposed to pornography for a very prolonged period of time, some degree of emotional neglect is going on, and the child must be showing some behavioral signs. At this stage, seeking professional help is must, because the parents may not have the professional know-how how to handle a child like this. So it is always better to seek a professional help to what to do with a child who has shown uh, behavioral changes and which has to be dealt with in a very, very professional manner. But one thing for sure, never ever blame the child. Many of the parents start blaming the child that it is your fault and you are such a bad child that you are looking into such material, etc. Again, you have to sit with the child, tell the child that this is not your fault, that you have been exposed to it. It is the fault of the perpetrator, and that perpetrator will be taken care of. It is a good thing that you have told us about this pornographic material, or whoever is sharing with this pornographic material. So once the child has the confidence of the parents, he will open up and he will reveal more and more information about the perpetrators. So it is important not to have the blame game at this time going on, that blaming the child for everything, and do not rush into taking action. Sit down, cool down, and take a very cool, calculated step, because the parents also want the perpetrators or the offenders to be taken to task. But this has to be done with plenty of evidence. So whatever evidence the parents can collect, they should collect it before reporting it to crime, because even if you are reporting it to the cybercrime wing, they would also need some information, some forensic evidence with which they can go ahead. And if they can get hold of the addresses of the perpetrators or online addresses, they must try to gather information as much as they can before reporting it to the cyber wing. It will be easier for them to reach the culprit.
Thank you, ma'am. Thank you so much. I have one last question. How common is child abuse done by teenagers in their late teens?
Well, I don't have an exact figures, but most of the teenagers, particularly, it is very common in older school boys and girls abusing and smaller children. It is very, very important, and I think at a school level, the teachers has to keep a track of whatever is going on, because even if they do not have any ulterior motive, at times they try to experiment, because this is an area where not only children but also the teenagers like to experiment with. They try to experiment with drugs, they try to experiment with sex, they try to experiment with the other, because this is an age where they are very daring and they would like to uh, sail in an uncharted sea. So in this case, the school as well as the parents need to be very, very vigilant about younger children as well as with their teenage children, that what type of company they are keeping. Try to meet their friends, try to meet their friends' families, and try to find out whether they are in a good company or not. It's always better to invite their friends at home so that they will come to know about these friends. Try to visit their families so that they will not only develop a good cordial relationship with the family members, but they also try to know. And at times try to do a spot check when they are at home and they are all alone at their home, keeping in mind that this is a time that their privacy does really matter. But to keep an eye on them at this stage is very, very important, because if they are not being checked at this stage, then a lot of these children go ahead. These days, a lot of these teenagers are now into drugs and a number of similar stuff, and the parents have to be very, very vigilant.
Yes, ma'am. Ma'am, I would now like to conclude our question and answer session. Thank you so much for so much information. I personally enjoyed this very much. It was a topic that really needed discussion and needs to be spoken about more, especially in our society.
Thank you so much.
Thank you, ma'am. This concludes our session for tonight. I would like to thank our speakers for giving us their time and valuable information and for joining us to share their experiences. Thank you to the participants for joining in. We hope that you have gained as much as we have through the session. Do not forget to fill the feedback forms, as the certificates will be distributed based on that. Thank you, Dr. Zayed, for being an amazing co-host, and the rest of the team for helping us conduct this session. Our next session will be held tomorrow at the same time, same virtual space. The next sessions will be a continuation of the pediatrics in relation to COVID-19. Thank you to our speakers again for sharing such beneficial information and taking out such valuable time to increase our knowledge. A special appreciation for Professor Samia Naimullah for all her efforts. She's our patron as well as our advisor for the academic team, and these series would not have been possible without her. Thank you so much, Dr. Sabah Akhtar, the co-founder of VFP, and also the advisor for the academic team. She has been the backbone of our team throughout these sessions. Thank you, Mr. Iftikhar Yazdani, the CEO of Rahe Qamar and a partner of VFP. His company provides voluntary IT services for this noble cause. Thank you, Dr. Rabil Tarek, who is the co-founder of VFP. Thank you, Dr. Maham Khalid, the co-director of the academic team. Thank you, Dr. Muhammad Ali Budd and Dr. Sohaib Ansar, and many others for supporting us throughout the session. Thank you on behalf of Team VFP, Team Yardim, and Team RMU. Allah Hafiz.